Hello and welcome to the Motivational Midwife. I'm Lynn Jones and today we're going to be looking at the antenatal booking appointment. So antenatal care and specifically the booking appointment. This, in my opinion, is probably one of the most important appointments in the whole of the pregnancy because it's the first opportunity you have to meet the woman and her family and build a relationship, build a rapport with her. And this has certainly been a challenge during COVID, as many of these appointments have not been face-to-face, and it's much more difficult to build that relationship over a telephone or over a Zoom meeting. You are essentially an ambassador for the trust you work for, and all trusts want to attract people to their hospitals because there's money involved, obviously. The health service and hospitals have to be really efficient at how they run. So the impression you give and the care that you give really will colour her opinions of the service that is offered at your trust and the hospital itself. And many women choose to have their babies in hospital. And for many women, it is their first exposure to hospital services, full stop. So how you are and how you offer the care and the care you offer and the experience she has will colour her judgment on the trust as a whole. So if she has a really good experience, she is likely to recommend that hospital or go back to that hospital for treatment for anything else that's not pregnancy related that she might have. If she has a very poor experience, she may not wish to go to that hospital. She may want to go to a different hospital, even though maternity and the main general side of the hospital are separate entities. So it is quite important that we provide high quality care and give these women a good experience. It's an opportunity to find out what her wishes are for her pregnancy and her birth, and to discuss place of birth. And remember, women have choice. It may not always be the choice you would choose for them, but they do have choice. And we, as midwives, our role is to provide evidence-based information for women to make an informed choice around their care. And our role is to respect their choices, even if we don't actually agree with them. It's an opportunity to discuss with the woman the most appropriate care pathway. So essentially you are risk assessing as to which is the most appropriate care pathway for her. So does she need to be entirely midwife-led care? Does she need to have a little bit of a mix of obstetrician and midwife, or does she really need to be primarily obstetric-led pathway, which would be the most appropriate for her in this pregnancy? And it's also an opportunity to get some baseline observations, so to give you that starting point for various observations in the pregnancy, and then you can see how they respond during the pregnancy. So in the first instance, we get some demographics. Okay, we need to gather that basic information of who she is, where she lives, her contact details, her which are the most current phone numbers, who she wants down as her next of kin, and it's not always her partner. It's also can highlight to you, if you know where she lives, whether or not sometimes more social care input may be necessary. For example, in the trust where I work, we have one of the third most deprived areas in the country. So if I was booking a woman from this area, I may be alerted to the fact that she might need a little bit more social care input than someone else, for example. Not necessarily, but she might. So it may give you an indication as to whether or not extra care may be needed. Getting her medical history as well. So does she have any medical conditions that she is being treated for or has had in the past that could be an indication? So thyroid issues, diabetes, epilepsy, asthma, anything really that she is currently or has been treated for in the past. It's also a good opportunity to ask about smoking. Is she currently a smoker? Talk about the impact of smoking on the pregnancy and offer to refer to smoking cessation clinics, both for her and her partner. It's always talk about passive smoking if she hasn't smoked, but he does. Also a good opportunity to talk about any medications she may be on, any drug use, either recreational or prescribed drug use. Has she had any previous surgery, not just caesarean sections, but any surgeries at all, particularly if it's uterine anyway, because that could have an impact on the care you give or the pathway she's on. But if she's had surgery in the past, even though you might think it's not hugely relevant to the pregnancy, particularly if it's been under a general anaesthetic, then we are fairly reassured that she's had a general anaesthetic in the past and not had any problems from it. Is she allergic to anything? And it's vital that any allergies are documented prominently in any records. And many records are now electronic. We need to make sure that the women actually can access their records because not everybody has a computer, not everybody has a smartphone. So it's good to ascertain at this booking appointment whether or not she'll be, if you've got electronic records, whether she can actually access those. And if she can't, then you need to find out what your trust's policy is around giving women their records. Sometimes it is that you just have to print them off and she keeps a paper copy with her. Family history. So family history can be quite important, particularly if there is first degree relatives with things like diabetes or her mother's perhaps had preeclampsia in her pregnancy. This can slightly increase her risks of various things, but again may alter the pathway that would be most appropriate for her. And then looking at obstetric history, so any previous births that she's had, how many has she had? Has she had any miscarriages or terminations? The terminations, were they for social reasons or were they for fetal abnormality? And at what gestation did she have those terminations? Because again, particularly if it was for fetal abnormality, she's likely to be extremely anxious and it may change the pathway somewhat. You may get her an earlier appointment with an obstetrician or some extra scans may be needed during this pregnancy. What types of birth did she have? So did she have a spontaneous vaginal birth or did she have an instrumental, a forceps or a ventouse? And can she remember why she had the instrumental? Did she have any perineal trauma with those births? And what type of trauma was it? Can she remember, was it just a small tear or was it a more extensive third or fourth degree tear? Did she have a caesarean section? And if so, was it an unplanned or emergency caesarean section or was it an elective caesarean section? Can she remember the weights and gestation of her children? Because this can help flag up any small for gestational age babies that weren't perhaps picked up last time, or if she did have a small for gestational age or a large for gestational age, it may change the pathway that you are suggesting she goes on. Certainly for small for gestational age, you would be monitoring the growth much more frequently than you would for somebody that hadn't had a small for gestational age baby. And the current status of those children, are they alive and well? Do they live with her? because sometimes this can flag up previous social service involvement or even current social service involvement. And it's important to ask that question as well. If she has attended on her own, then it's important to ask around the question of domestic abuse as well. And does she feel safe at home? If she has attended with a partner, then it's not necessarily appropriate to ask that question in their presence. But I would suggest that you find out what your trust's policy is around asking the question. It should really be asked in every trimester, but you have to pick your moment. So also at this appointment, and this is a huge appointment, there's a huge amount of information we need to get from the women and also that we need to give to women. And you need to really consider as well, if English is not her first language, that translation service, interpreting services may be necessary, and this can make the appointment much longer. So it may be appropriate to maybe split that appointment into 2 appointments. So we can get her body mass index. This will give us a baseline because obviously increased body mass index will predispose her to a number of issues during the pregnancy. We will get a baseline blood pressure, and this is very important when monitoring the blood pressure throughout pregnancy to see whether there has been a significant change in that blood pressure. And urine analysis as well. And with body mass index, if women are starting pregnancy really with morbidly obese, there's certainly in some areas used to be, I think it was with Slimming World, did free Slimming World for women in pregnancy to help them during the pregnancy with them not specifically losing weight, but certainly not gaining any more. And then we start giving them a lot of information. So we talk about diet, healthy eating. What is that? And you need to ascertain what her normal diet is. Is she vegan? Is she vegetarian? How are you going to tailor your information to those clients? Talk about what foods to avoid in pregnancy and why we need to avoid those foods in pregnancy. It's not enough to just say you shouldn't eat A, B, and C, and you shouldn't drink too much coffee. And you need to actually back that up with why we are suggesting that this is not a good thing to do during pregnancy. And signpost them to resources where they can find out more information. And again, if English speaking is not if English is not the first language of the client you are seeing, then it may be that you can already have some printed out resources in their own language, which will make life easier for you. Many of the government websites actually have a lot of resources in multiple different languages. And then we talk about screening, okay? And it's important to remember that women have choice around screening, and I don't think they actually think about blood tests as being screening. I think most women actually just assume that blood tests are part of kind of the normal process of pregnancy, and they don't realise that they do have choice about it. So there are a number of blood tests we have that we offer women, and some of them are with the blood tests. They're normally done quite early in pregnancy, but again, you need to check with your trust what it is. With some of them, really they need to be done pre sort of 12 to 14 weeks ideally. So some of the blood tests we look at, and there may be extras within the areas you work, but we generally would offer a full blood count to give us a baseline hemoglobin level. And because this can highlight, if it's low, it can highlight that she may need some iron supplementation. We don't routinely offer iron supplementation to women. We do, however, encourage them to have folic acid early in ideally preconceptually. But by the time they get to sort of about 12, 13 weeks, it's no longer necessary. So the full blood count will give you a baseline hemoglobin level and a group and safe serum. Okay, so this actually determines their blood group and rhesus factor. And this is important in terms of the rhesus factor, particularly because if they are rhesus negative, we would offer prophylactic anti-D, and we'll go into those in a bit more detail in a different session. I'm not going to go into it in great detail now, but there are implications for the fetus and future pregnancies with rhesus negative women if they have a sensitizing episode. So the family origin questionnaire, which is again offered to all women, really highlights whether there is a thalassemia or sickle cell risk there. And for women who are high risk of diabetes, then random blood sugars or glucose tolerance test may be offered as well. And then there is screening for trisomy, and obviously this varies slightly depending where you are in the country. But this is your screening for Downs, Edwards and Patel syndrome. And it's often, depending if you're having the quadruple testing or triple testing, and some will be combined with nuchal scanning as well, which I believe needs to be done before 13 weeks and 6 days, I believe it is. But I might be wrong on that. I may have to check that. And remember, screening only highlights the risks of there being, the chances of there being a problem. It does not tell them there's definitely a problem. They would need to be offered diagnostic testing if their chances of having a baby, an affected baby, comes back as a high chance. Then they would be offered a diagnostic, more invasive testing, which again we will go into on another session. And scanning, ultrasound scan. Okay, routinely in pregnancy, women are offered 2 scans. The dating scan quite early in pregnancy, although I have to say it does always surprise me that we just don't accept women's dates and we change them sometimes. Even when women know exactly when they've conceived, we still alter them for the scan. Scans are not infallible, and they do have a margin of error. And the anomaly scan, which is usually done around the sort of 18 to 20 week time. And women very much, in my experience, don't really understand the purpose of the anomaly scan. They see it as the day I'm going to find out what my baby's sex is. And actually that's not the purpose of the scan. In my day when I first trained, actually sexing the baby was not on the agenda at all. And I'm not sure that was a bad thing, to be fair, because I think you understood more what the purpose of the scan was back then than women do now, because they become quite tunnel visioned about finding out what the baby is, that they forget that the purpose of the anomaly scan is to look for abnormality. And again, as I've said, scans are not infallible, and they will pick up large abnormalities. Smaller ones they may miss, and actually they only pick up about 50% of cardiac abnormalities. So they are not infallible. And I think, women need to understand that the purpose of the scan is looking for abnormality, because often when an abnormality is detected, they're not quite prepared for that, because they had been so focused on finding out what the sex of the baby was that they hadn't considered any other things going on in the scan. And so the next steps at the end of that appointment, you make sure that they have your contact details, or how to contact the hospital if they need any advice or help. Many hospitals have helplines, but certainly there will be some contact number that they can access 24 hours a day to get help and advice from. You need to make sure that they have their next appointment, and that you've discussed the schedule of appointments with them and where those appointments may be. And again, particularly with COVID, some of them may be not face-to-face appointments. And obviously answer any questions that they may have about their pregnancy. And there you have it, the antenatal booking appointment. I hope you found that useful. If you haven't subscribed to the channel, please do, and I look forward to seeing you next time.